The reason I'm even mentioning myocardial infarction is I think you need to know what a myocardial infarction is and in order to know what it isn't. So again, this will be covered in detail in 495. But an MI is basically the pain is different from other pains they've had. It lasts longer than 15 minutes, usually closer to 30 or longer. The pain and pressure can radiate to their chest, to their jaw, into their back. It can go down their arms. It occurs without cause, a lot of times in the morning. They have no or very little relief from rest or nitroglycerin. Myocardial tissue abruptly and severely is deprived of oxygen because of the occlusion to the blood flow. This is a true blockage. We now have cell damage and tissue death. Because of that blockage, you have hypoxia. The patient will have shortness of breath. They will have fear, anxiety. They will have dysrhythmias. You will see elevations in their ST segments. They will become very diaphoretic. A lot of times there will be a change in their color. They'll become very pale, very pasty looking. And the reason I mention the myocardial infarction is because if someone is having unstable angina that they have not had before, they're going to do the same labs, the same diagnostic tests to see if it is a myocardial infarction. Cardiac markers show myocardial damage. The troponin, the CKMB, and the myoglobin. They'll also do serial lipids. They'll do blood coagulation studies. They'll do a set of ABGs. They'll look at their electrolytes. And they'll do a complete blood count. They will do a 12 or maybe a 15 lead EKG. And if the original laboratory tests come back well and there no significant changes on that 12 lead EKG, then they're probably going to go with a more conservative method because the patient is not having a heart attack or a myocardial infarction. So then they're going to probably plan to either do a stress test or a cardiac catheterization. A lot of times they will do a stress test, whether it is an exercise stress where the person actually runs on a treadmill and then they take images of their heart before and after to see if there is ischemia. A non-stress test is when they do the same thing, but they do it with chemicals, with medication, so that they inject medication so that the heart acts as if it has been exercising to see if there is ischemia. They may do a cardiac catheterization to see if there is blockage, to see if perhaps they can put a stent in and prevent the patient from actually having a heart attack. They'll do an echocardiogram that will show the blood flow to see if there's any valvular problems, and we'll be able to measure the ejection fraction. They will do a chest x-ray. Now, a chest x-ray is not going to show a heart attack, but it will show if there has been, if their lungs are clear, if they have cardiomyopathy. You can see the enlarging of a silhouette of the heart on a chest x-ray. So the treatment for the myocardial infarction, some of them look familiar. We're going to give nitroglycerin, which is a vasodilator, so it can help to decrease the pain. It can also help to increase blood flow. Oxygen, because remember with the MI, the necrosis can decrease the oxygen supply. They're going to give aspirin because it inhibits platelet aggregation and vasoconstriction. Now, they generally do not give morphine to a patient who is just having unstable angina. That is reserved for the patient having the MI because it is given for pain unresponsive to nitro. And what that morphine does is it not only decreases the pain, but it decreases the O2 demand. Okay, now back to angina. Now, After 1 week, I've already learned this much. And I hope you've learned a few things yourself. I know you're going to ask me, Ms. Redder, will MI be on the test? Well, yes and no. Will the majority of MI be on the test? No. What differentiates between unstable angina and an MI? Yes, that is very probable on a test to see, is it chest pain that lasts longer than 15 minutes? Is it relieved with nitroglycerin and rest? These are things that, yes, you would see on a test. So the word MI may come up. What is the most deadly type of acute coronary syndrome? That would be an MI. So yes, the words myocardial infarction may be on your test, but the treatment and all about stress tests and cardiac catheterizations and blah, 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 no. But yes, the word MI may be on your test, but it's more about being able to tell the difference between the unstable angina, chronic stable angina, and the MI. Okay, now back to angina. So now we're back to talking about our unstable angina patient. Now with unstable angina, so we're going to assume that the patient came in, had chest pain, an MI was ruled out. Okay, so now the patient, it's unstable angina is stable and it's chronic. I hope that makes sense. So patient comes in through the emergency department. First time I'm having chest pain. We have to rule out an MI first. It's called unstable angina, rule out MI. We have now ruled out that MI. And so now we are treating his or her chronic stable angina. Okay. So now what do we treat them with? Nitroglycerin. For patient education to go home, for nitroglycerin, what they're going to do is they're going to sometimes wear a patch. The patch needs to be applied to a clean, dry, hairless skin. They need to rotate it. If it causes them to have a headache, they can place it a little bit lower. Either don't place it they sometimes will not place it on the chest, place it on their arm, and then they won't have the headache from it. Most patches are removed after 12 to 24 hours to prevent drug intolerance. The other daily medication that the patient may take is Imdor, which is another nitrite, which will help, again, with that vasodilation to keep them from having the chest pain. Now, when they're having an attack, that's not when they're going to use the oral nitroglycerin or the Imdor. It's when they're going, or the transdermal patch. This is when they're going to need their rescue or their PRN dose of sublingual nitroglycerin. Now, the sublingual nitroglycerin can either be a spray or it can be a bottle. And, like either one of them's in a bottle, but it's like a little bitty tiny pill. If you're ever giving nitroglycerin and it's a little pill, don't touch it. You want to make sure you pop it right out into the cup and then put it into their sublingual space. Because if you get nitroglycerin on your hand, you will get a headache. Sometimes the transdermal nitroglycerin, if you touch it, especially if it's a paste, that can cause some serious a serious headache. So the sublingual nitro, the patient needs to get a new bottle every 3 to 5 months and needs to be kept in a dark space. Doesn't need to be left in the car. It doesn't need to be, they want to keep it in a cool, dark space. It comes in a brown bottle, both the spray and the little pills do. And they want to make sure that not only do they replace it every 3 to 5 months, but when they take it, they should feel a tingling underneath their tongue. And if they don't feel a tingling, that's generally a sign that their nitroglycerin is too old or is inactive. All right. You have to you teach the patient, if you are having chest pain, you rest, you take the sublingual nitroglycerin every 5 minutes for 15 minutes. That's 3 pills. If you're still having chest pain or shortness of breath, or your chest pain does not feel like your normal angina, it is a reason to call 911. And tell them that. Now remember, if you've had to take all 3 of your nitroglycerin, don't jump up and go do something, because it can cause a headache and dizziness. So for nursing implications, when they're first starting these medications in the hospital, we're going to want to monitor their blood pressure. We want to make sure that we tell the patient on discharge that they should not take nitroglycerin if they are taking drugs for sexual dysfunction. And a lot of times patients will not think that because they're taking a medication for sexual dysfunction that it's important to tell the nurses on admission to the hospital. They're embarrassed, or they really don't think about it because they just keep it at their bedside table. And they're like, oh, I didn't think that was like a real pill. So I always don't assume that they don't take something. I tell everyone the same thing. Now remember, you can't take nitroglycerin. If you have ever been taking, Viagra or something for sexual dysfunction, you can no longer take that because now you're required to take nitroglycerin for your heart. I just kind of say it, and then they can choose whether or not it's information that they need. Also, if a patient comes in or is in the hospital and has a patch on and they have a cardiac arrest, you want to make sure that you remove that patch prior to defibrillation, because that patch can cause arcing and can cause a burn. Okay, beta blockers. Nursing implications. You assess your heart rate and your blood pressure. They generally will hold a beta blocker for heart rates less than 50, or if the patient is symptomatic. You want to always assess these patients for signs of heart failure and for shortness of breath. Patient education. When they're going home, remind them, don't stop it, but if you forgot a dose, don't double up. And more information on that is on table 38.4. Antiplatelets. Patient education. Report unusual bleeding. Avoid over-the-counter pain medications. Take with food so that you don't have GI upset. And report any tetany or ringing in your ears, because that can be a sign of aspirin toxicity. Lastly, our patient with that chronic stable angina sometimes will decide that they want to try to modify some of those risk factors. And with modifying some of those risk factors, one of those can be exercise. With that, cardiac rehab is a great place to start. So getting them enrolled in a cardiac rehab upon discharge from the hospital can help them begin walking in a safe place. The cardiac rehab nurse, we usually have them start walking about the same amount as they were in the hospital. And the rehab nurse will also help them learn how to check their pulse so that they can know what their resting heart rate is and what it is when they're exercising. And when they have gone into the orange zone is what they call it at cardiac rehab, when they have when they're getting too high and that they need to scale it back some. Even if they don't go to cardiac rehab, the nurse in the hospital, when talking about activity with coronary artery disease, they can talk about, start slow. If you've been walking, just to the bathroom here in the hospital or down the hallway, start with walking to the end of the driveway. You also want to talk to them about not straining when they're having a bowel movement, because if you strain when having a bowel movement, you can cause some excess workload on the heart. So if you have any questions or anything about acute coronary syndrome, please feel free to bring them to class or give me a call, and I will see you guys in a little bit.